So my title is ICG Guided Minimal Invasive Anatomical Liver Resection. My content are as follows. I briefly wrap up the history of liver anatomy. In 1543, there are two scientific revolutions occurred. This area is a Renaissance, and first one is Copernicus revolution of heavenly spheres. Second one is human body liver anatomy proposed by Vesalius. The Middle Age, the liver anatomy was made animal, garland, but Renaissance era and Vesalius studied anatomy by human, by cadaveric study. In the 16th century, Vesalius proposed firstly morphologic liver anatomy. At the first of 1538, this liver lobulated like an animal model. But after 5 years later, he studied the human cadaver study. His liver morphology is similar in a human liver like this. The Vesalius is a father of anatomic studies. After that, Gleason, 17th century, first described the vascular liver anatomy. This study made by dye injection. Used dye is colored milk, and this study is first dye injection, by Gleason. After that, late 19th century, Cantley, he proposed a functional liver anatomy based on the so-called Cantley line between the gallbladder and IVC. It's a previous right liver, left liver division is falciform ligament, but from this Cantley legs is functional liver anatomy proposed by the Cantley line, gallbladder, IVCs, right liver and left liver. But based on the observation of liver abscess, he observed the right liver is atrophy and left liver hypertrophy. Due to the liver abscess, the liver is portal vein obstruction. And this idea of Makuchi's portal vein embolization is originate from this idea. So after 10 years later, in 1990s, Makuchi's 13 case is portal vein embolization for classic tumor for safety of major hepatectomy. And so paradigm shift towards liver anatomy from the morphologic anatomy based on falciform ligament to the functional anatomy by Cantley line, thanks to the James Cantley. In 1950s, the Quino first proposed the segmental liver anatomy based on the portal vein branch patterns. At that time, 1950s, other two representative case studies. First one, Hurjojo, is 1951, is this case study. And Healy, American study, is a Healy group is also studied cast. The Hurjojo and Healy group is studied focus on bile duct anatomy. On the other hand, the Quino is a case study based on portal vein, and three famous case study in 1950s. And based on this study, Brisbane 2000 terminologies are popularized, and this terminology is formal terminology between the surgeon and radiologist, hepatologist, and liver surgeon. So liver, first division, hemiliver is liver. Instead of lobe, lobe is misnomer because of lobe is originate from animal model. So right lobe, left lobe, right lobectomy is not correct terminology, misnomer. Instead of the right hepatectomy, left hepatectomy is correct terminology. Second order division is section. Third order division is segment. Segment is functional segment. So, in briefly sum up the history of liver anatomy as follows: 16th century's morphologic liver anatomy by Vesalius, and then 17th century's vascular liver anatomy is Gleason, and late 19th century's functional liver anatomy James Cantley, mid 20th century's segmental liver anatomy by Guino. Now, early 21st century's real liver anatomy was open thanks to the recent technology. I will cover the main topic, ICG guided anatomic liver resection. This is our laparoscopic setup. So in this setting is a resident training program. So one is 3D reconstruction imaging and ICG guided hepatectomy. It's very safe and blood dissection like this. We can identify the intrahepatic vascular anatomy by the 3D reconstruction imaging, and ICG fluorescence imaging, we guide the exact plane like this. Second grade resident, he performed the laparoscopic liver resection safely like this, even though first time, very safe setting. And our laparoscopic setup mainstays, two mainstays, simulation by 3D reconstruction imaging and navigation surgery by ICG fluorescence imaging. So ICG fluorescence imaging liver surgery is very useful for the tumor localization and anatomic plane and bile duct anatomy. Yes, so the conventional laparoscope view is cirrhotic liver. We cannot identify the tumor location, but the ICG fluorescence images, you can identify exact the tumor location like this. So very helpful for the tumor resection. And now the anatomic liver resection is proposed Makuchi 1955, his dye injection method. But first dye injection method is Gleason. Gleason inject the colored milk by the main portal vein. Makuchi, instead of peripheral portal vein, inject under the ultrasound guidance. So this is first the proposal of anatomic liver resection in 1985. The anatomic liver resection, two mainstays, complete removal of tumor-bearing portal territories, the theoretical background, the tumor-bearing portal vertical identification, and second one is intersegmental plane is followed. Sometimes intersegmental plane is very curved line and not flat, so it is difficult to identify the intersegmental plane. So, do you know the first description of intersegmental plane? The Healy group, 1954. Healy group studied 100 case study. He found that the intersegmental plane there is no Gleason branch, only hepatic vein runs. In 1954 description, like wrong intersegmental pulmonary vein, this plane between the segment, only hepatic vein are also intersegmental plane. So this paper is first description of intersegmental plane and intersegmental vein in 1954 based on 100 case study. And 2020 Tokyo terminology is also the anatomic river resection following intersegmental plane is the law of ICG. ICG enable visualization of intersegmental plane, and ICG reference image is a game changer. So how to identify intersegmental plane? So we cannot identify the intersegmental plane during parenchymal transection, but ICG reference image, you can see the exact plane like this, the green and non-green area like this. Even though very curved line, we can identify the exact plane. The right intersegmental plane between the right anterior section and right posterior section is very curved line. We cannot identify the exact plane without ICG reference imaging. But thanks to the ICG reference imaging, we can identify the exact plane, right? This first, this clamping right posterior gleason pedicle. This curved line, you can identify the exact plane, right? This plane is, there is no gleason branch, only hepatic vein runs. This branch is from the right posterior gleason branch, so there is no clip, no bleeding, no barlic, like this. This plane is very curved line. If there is no ICG reference image, we cannot identify the exact plane. But this line is very curved line. You can see the exact plane thanks to the ICG reference imaging. Another point is we can identify the boundary between the caudal lobe and right liver, segment 7, and boundary between the segment 7 and caudal lobe, you can identify. We usually transect the parenchyma in case of right hepatectomy or right posterior sectionectomy. We can follow the mid-plane of IVC, but this plane is not anatomical plane because partial resection of caudal lobe. So we can identify the exact plane between the caudal lobe and right liver thanks to the ICG reference imaging. So another example of an exact plane using the robotic platform. Nowadays, I sum a little bit the concept of liver parenchymal transection from the dissection to the detachment. Intersegmental plane is there is no gleason branch, so the left hepatectomy, robotic left hepatectomy, is the first clamping of left gleason pedicle. And this plane is so-called cantiline, mid-plane. There is no gleason branch, so we can detach like this. There is no gleason branch, so not dissection, only detachment. This is embryologic plane. Right liver is originate from porta vein, left liver umbilical vein. This is anatomic plane. It's very anatomic plane. It's only detachment. This is there is no gleason branch, so very easily to dissect detachment. Like the detachment hala plate, intersegmental plane is also detached like this. There is no clip on the liver surface, only clip the hepatic vein branches. So our concept is a little bit changed from dissection to detachment along the intersegmental plane, thanks to the ICG reference imaging, like this. Very clean surface, like this. And so this paper is a very well-known paper. The remnant liver ischemia is related with survivor, for survivor. Theoretically, anatomical liver resection, there is no remnant ischemia. But this paper, even though anatomic liver resection is, however, severe remnant liver ischemia occurred in about 30% after anatomic liver resection. So this paper is 2007. Is locally hepatic ischemia after liver resection. It's right hepatectomy, around 25% remnant ischemia. Left hepatectomy, 50% ischemia. And even though left lateral sectionectomy is also 8% liver ischemia occurred. Why? At that time, the without ICG French imaging, anatomy liver resection is very theoretically it's very low. So I will briefly cover the representative anatomy liver resection. People of left lateral sectionectomy, we usually anatomy landmark is falciform ligament, but using the ICG French imaging, so anatomy plane is not falciform ligament around the right side, but falciform ligament, the left side is anatomic plane. Because of this is the umbilical portion of anatomy, the cranial branch of umbilical portion of embryologically is the left liver, left segment 2, porta vein is only developed. After that, segment 3 and 4 is a common trunk. So the cranial branch is sometimes it is difficult to identify the segment 4 and segment 7. So this branch is cranial branch. Because of cranial branch, the falciform ligament is not anatomical plane in left lateral sectionectomy. Another people, next left hepatectomy is people is it is difficult to identify the left liver and paracaval portion. So another important people is very curved horizontal plane. So we can identify the exact boundary between the left liver on paracaval portion thanks to the ICG French imaging. It's another posterior sectionectomy. It is difficult to identify. We usually cut straight line along the right hepatic vein, but this plane is very curved line. Another point is caudal lobe. We identified to difficult the exact plane between the caudal lobe and right posterior section. So I show the very curved line. Another example is lobotic left trisectionectomy is ICG French imaging. So very curved line is this line without ICG French imaging. It is difficult to identify this plane. There is no Gleason branch. Is very carefully dissected. Thanks to the ICG French imaging, we can identify the exact plane like this. And after that, this patient revealed no remnant ischemia after the left trisectionectomy. This plane is very curved, right intersegmental plane, no congestion, no ischemia. After that, he discharged after operation 6 days. Final one is representative right hepatectomy. So people is here. Usually conventional right hepatectomy is consists of resection of right liver and partial caudal lobe. So we proposed the real anatomic right hepatectomy preserving the paracaval portion, a caudal lobe. We first dissected right anterior and posterior Gleason pedicle for preservation of caudal branch, and then we parenchymal transection river parenchyma using the ICG difference imaging. You can see the how that process and paracameral portion exactly. So this procedures have an advantage of real anatomy. Right hepatectomy is as follows: the preservation remnant liver volume or 4 or 5 or large caudal lobe is 10% of preservation remnant liver volume. And many cases, the conventional right hepatectomy is bile leak and myelomyositis, but this area, paracameral portion, because this area is not anatomic plane, the prevention of bile leak, myeloma, we cannot dissect the IVC because this area is not right liver, but paracameral portion. So minimal injury of IVC and short hepatic vein. And in salvage liver transplantation, less adhesion, IVC, and right hepatic vein in these procedures. So another important point is the oncologic outcome between the anatomic resection versus non-anatomic resection is questionable because real anatomic resection group, in this group, non-anatomic resection is included. So based on strict definition, real anatomic resection is very small portion. The gray portion is large. So after this, based on strict definition by ICG difference imaging guided anatomic resection versus non-anatomic resection is a real oncologic outcome, oncologic benefit of anatomic resection will reveal a next further study is proposed. And final subtopic is anatomical segmentectomy video presented. I will show the extrahepatic glycine and transfistular glycine approach. PAM consensus meeting, 3 types of glycine approach is the first 2 glycine approach from the liver hilum, extrahepatic or intrahepatic glycine approach based on according to the low parenchymal transaction. And final one is a glycine approach from the parenchyma after the major parenchymal transaction. We tailor the strategy, the extrahepatic, intrahepatic, transfistular glycine approach, performing anatomic liver resection based on the branch pattern of portal vein, location of target glycine, and anatomic variation, final one in technical feasibility. We summarize that, and each techniques have advantage and disadvantage. We published this paper, a tailored strategy for dissecting the glycine pedicle for anterior sectionectomy. Extrahepatic glycine approach is ideal, but every case is not possible. But transfistular glycine approach another good option, so-called bail-out procedure. And so I'll show the extrahepatic glycine approach and transfistular glycine approach. Those are segment of right anterior section. Anatomic resection is very difficult procedure. We published this article this year. I'll show the laparoscopic anatomic resection of those area using the extrahepatic glycine approach and ICG guidance. We check the target glycine pedicle by 3D reconstruction image. A tumor is located dorsal area. We first dissect the right anterior glycine pedicle. Second order glycine pedicle is extrahepatically, and right anterior and right posterior glycine. And thanks to the caudal view, we can approach the dorsal and ventral glycine pedicle of right anterior section. This one is branch of dorsal branch. And we cut And then the right ventral and those are bifurcation area we can identify. Very similar to the 3D reconstruction image, we can identify this main dorsal pedicle. And this shape is 3D reconstruction simulation. It's almost the same by 3D reconstruction imaging, like this. And we can follow the ICG forensic imaging, the tumor location here. And this plane is anatomic plane, easy to dissect. Sometimes we use the seizure like this. During parenchymal transection, there is no bleeding, no bowel. The seizure is this resistance like this. Without ICG and 3D reconstruction imaging, this type of dorsal resection is a very difficult procedure. But right hepatic vein here, and you can identify the exact plane, the dorsal and ventral right posterior section like this. After completion of our parenchymal transection, we check the 3D reconstruction imaging. It's very similar to between the 3D reconstruction image and operative view. And next, a video clip is transfissural glycine approach. A transfissural glycine approach is summarized by Professor Quino. But transfissural glycine approach means parenchymal transection along the main polar fissure, umbilical fissure. After that, glycine pedicle approach like this. Originally, transfissural glycine approach proposed by Dong-Taek Dung is he already performed anatomic segmentectomy before Makuchi. He performed around 400 anatomical segmentectomy in 1970s. His main technique is finger fracture technique like this. This one is segmentectomy 8. You can see the ventral and dorsal branch, and intersegmental plane is the right hepatic vein exposed. Second one is segmentectomy 5. Is anatomic plane between the middle hepatic vein, right hepatic vein, segment 5 branch, sometimes from the segment 8. This is a very anatomic figure. I show the anatomic segmentectomy 8 using the transfissural glycine approach, a laparoscopic approach. So we check the target glycine pedicle, and we first identify the midplane, opening the midplane. After completion of right pedicle and identification of midplane, after opening of midplane, you can see the target glycine pedicle. And middle hepatic vein here, and target glycine pedicle. After opening of main polar fissure, you can see easily, directly identify the target glycine pedicle. You can see the G5, G8, right anterior glycine pedicle. After the opening of the main polar fissure and we dissect the target glycine pedicle where we inject ICG like this. This another landmark vein is right hepatic vein. As you can see the exact boundary of segment 8 and segment 7. After completion of parenchymal transection, you can check the remnant target vessels of middle hepatic vein, right hepatic vein, GS stump, like this. Final video clip is loboric segmentectomy 5. And today live surgery maybe segmentectomy 5. We first dissected the right anterior glycine pedicle and clamp the right anterior glycine pedicle. We inject ICG first time. Nowadays, very low dose, the 0.5 milligram inject. We can identify the midplane and right anterior section. And this middle hepatic vein dominant patient, so we cut the middle hepatic vein. After the cutting of middle hepatic vein, in this case, segment 5 glycine pedicle 3 are 3. And based on the 3D reconstruction image, first segment 5 glycine pedicle ligated, transected. And second one is also final segment 5 glycine pedicle and transected and released the bulldog clamp, and we inject second inject of ICG. You can see the reperfused of segment 8 area, double injection of ICG technique using the transfissural glycine approach, like this. And after completion of parenchymal transection, we preserve the segment 8 pedicle, and we transect the 3 segment 5 glycine pedicle, like this. To wrap up my presentation, the evolution of liver anatomy and anatomic liver resection as follows. 70s vascular anatomy by Gleason, and late 19th century's functional anatomy by Cantley, James Cantley. Mid-20s functional and segmental anatomy by Guino. In 1985, anatomy liver resection proposed by Makuchi. And this era is new world of real anatomic liver resection are opened thanks to the recent technology. Thank you for your attention.